I'm Glyn Hayes. I'm originally a GP from Worcester in the UK, where I spent 30 years as a GP. I also spent 10 years as Medical Director of computer suppliers, AAH Meditel and Torex Health, and then 10 years as Chair of the British Computer Society's Health Informatics Forum. I'm also President of the UK Council for Health Informatics Professions and Secretary General of the European Institute for Health Records. I think innovation is a fascinating thing because one of the great things about it is you do not know what it's going to achieve, what it's going to result, what's going to be the result. I mean, in the early days, I started developing systems in primary care in the UK back in the late 70s, and we were then developing systems and playing with them, putting them into my own practice and finding what they did. And that iterative process meant that we kept on changing, i.e. innovating what we were doing, as a result of our real experience in the real world. And that's one thing that's always stayed with me, that innovation is great and one can come up with brilliant ideas, but what you really need to do is to test them against the real world. There have been a lot of catastrophes because systems have been imposed on particularly the medical profession, but on all the clinical professions. There's a tendency for administrators, managers, politicians to want to decide what ought to be done and to produce the systems that are supposed to do it without taking into account the needs, requirements and wishes of those who are going to actually handle these systems, which is the clinicians. And we've had a lot of problems with clinicians are not accepting systems because they see them as being interfering. They see them as being a distraction from the only thing they really care about, which is, of course, caring for patients. And so getting buy-in from clinicians before one starts an implementation is absolutely vital if it's going to be successful. We have become very much better at providing lots and lots of information to clinicians, whether it's laboratory tests, x-rays, weight measurements, blood pressures and so on. So now clinicians will find that in front of them is a whole plethora of information, so much that it's actually very difficult to assimilate because it's bits in silos of information. And the thing that we've got to do is to develop that information from being independent silos into something which presents a picture. And the most important picture in medicine, with medical data, is the context in which it's taken. And the usual example that I choose is that of blood pressure, where a blood pressure result, no matter how much you have around it in terms of measurements and so on, by itself does not have any great value, even if you graph it or you show trends or whatever, because the significance of that to a clinician depends on the context in which it was collected. So a blood pressure of, say, 140/90 in a 35-year-old woman will have one significance if she's in the middle of an anxiety attack, will have a completely different significance if she's on antihypertensive medication, and an even more significant difference if she's pregnant when it is actually raised and is a potential problem. So we have to learn how to present information in a meaningful manner to clinicians. There are a lot of work that's been done in terms of how we do that, particularly by the Dutch and by the Brits in the UK. And it's a question of how one structures it's the architecture of the record which makes the difference. It's one of the major differences in the delivery of healthcare now than it was in years gone by, in that patients have access to a great deal of information on the internet in particular. In the old days, what they would do was bring a cutting out of a woman's magazine, but now, of course, they have access to the whole of the internet. And I had a wonderful experience in years gone by when a patient came to see me and said, "Don't worry, doctor, I've sorted out what's the matter with me. I've been on the internet, I've used various decision support systems on the internet, and I know that what I've got is Wegener's granulomatosis, and therefore what I need immediately is immunosuppression." So I did what a doctor's supposed to do, and I examined him, and I said, well, yes, you've got lumps in your neck, you've got a rhinitis, you've got sweating, and you've got various other signs and symptoms, but it's actually not Wegener's granulomatosis, you've actually got a common cold. And this business of interpreting and an objective interpretation is very difficult for a patient to do, because they're the ones who are subject to it. And so when they go on the web and start looking at all this information, sometimes it can actually be that they get completely the wrong end of the stick. And that's, I believe, one of the roles of the clinician in the modern age. If I was going back 20 or 30 years to when I started, the thing that I think has changed most and had the most impact is the availability of information. When I went into practice, I primarily worked from information within my own head. Fine, there were the odd books I could look up, but actually one didn't tend to do that in front of a patient, because it was the patient looked at you a bit strangely if you were trying to look something up in a book. And we were, even then, were becoming very well aware of the fact that medical knowledge was increasing so rapidly that no human being could hold it all in their head. But now, when medical knowledge is so readily available, whether it's in electronic form, in one form or another, that's made a huge difference. It can be in terms of protocols and decision support. It can be just looking up information, which in the past one just couldn't do. And the other thing is that the patient's attitudes have changed. 30 years ago, the patients expected me to know everything. Now they accept that it's something which one can need to investigate and look up, usually with them, in conjunction with them, if there are things that need to be done, such as the choice of drug. I would hope that there is a greater ability for patients to get accurate and adequate information from the internet, which at the moment, as I've already said, is a bit too unstructured. And I think that also we need to get better at providing knowledge in a meaningful form to the clinicians. The problem at the moment is, if you do a search on whether it's a scientific search through PubMed or whether it's a Google search, you get so many hits. And we need to get a lot better, and we will get a lot better at providing the salient information at the appropriate time. And the other thing, which, because it's my personal particular interest, is I think we will get to the stage where the electronic patient record is providing significant benefit and help in terms of patient care. I think they stopped talking about centralised systems. The idea of a big national central database is the main reason why people have got so worried about this whole process. 20 years ago, I had all my patient records on a computer in my practice, which I was responsible for, and the patients didn't worry at all. It was only when we started centralising and communicating all of this, and I think we need to go back to having the localised databases, which can communicate when necessary, but under control, and where the localised databases are the responsibility of the clinicians, who, after all, no matter what people might think, are still trusted more by the population than just about any other discipline.